So, greetings, everyone. Welcome to COVID Impact 360 Conversations. I'm your host, Larry Cole, and today I have somebody I've been wanting to get on for a while, and his name is Daniel Duggar. And good morning, Daniel. How are you?
Yeah, I'm doing great, Larry, and yourself.
I'm doing very well. So, what I like to
Thanks
do at the
for having
beginning of these, what I like to do at the beginning of these is kind of give an introduction of how I know you, how we ended up coming on today, and that'll kind of give us a basis for moving forward. So
Sounds great.
I fir- I first met Daniel actually through Twitter or X, whatever you want to call it. I became a follower of his. He's a big time user of Twitter, and I started to follow his comments. And as I was saying to Daniel before the show started, I when I first came up with the idea of wanting to do a podcast, it had to do around I wanted to have interesting guests who were doing things differently in the long COVID world or in the COVID world. I tend to put them both together. Daniel, as it turns out, when I started to get him to know better and better, and he was commenting a lot on my posts, has developed something called Sand Scan, which is SAND scan. And when I started to read into what he was doing, the software and the testing of that, I went, I can see a show in there someplace. So I think that's kind of how we met, and then now we're here today. And Daniel, thanks for coming on.
Yeah, and thanks
So a
for
good place
having
to
me, Larry.
start. You bet. So a good place to start is what were you doing pre-pandemic? Because that's just a little of your background. Where do you live? All that kind of stuff.
Sure. So I live right outside of Nashville, Tennessee, in Franklin, Tennessee, where the Battle of Franklin took place. I've always had an interest in medicine and technology. One of the reasons why I think I've been so attracted to the neurological aspects of what is described as long COVID is I was actually born with a number of neurological conditions, communicating hydrocephalus being one, another called colpocephaly. The tissues that join the two hemispheres of the brain are malformed, the corpus callosum, and then the tissue that is found in between the two lobes of the cerebellum at the back of the brain is absent in me. And so I've struggled with that in various ways, for 43 years. And so, um, you know, I thought, well, of all that I can research, that would be the most fascinating, I think. Um, and then I started a Bell Bond software company in 2005 and still operate that today, called Bell Bond Software Solutions. So in taking that experience and then the neurological aspects of things, I often think about how the criminal justice system will be impacted from an attorney standpoint, from the accused standpoint. Before the pandemic, we had the trial penalty, right, where they would use plea deals and punish people in criminal cases. So, in thinking about it after the pandemic, I can't think of a better trial penalty than having an attorney that is suffering from cognitive impairment. Or a juror that is suffering from cognitive impairment. I certainly wouldn't want either one of them if I was facing a jail sentence or a prison sentence. So that's what I was doing pre-pandemic professionally. Personally, I was educating myself and living with a condition that's basically identical to that which individuals are living with today, a chronic SARS-CoV-2 infection, and of course I'm talking about a chronic HIV infection. And so that, I believe, well, I know it's really given me a leg up in the research and advocacy that I've been doing, because it was a quick and easy move from HIV to SARS-CoV-2.
Okay, why was it that easy? Why was it easy to move from the HIV world into the SARS-CoV-2 world?
Because of just how strong the parallels are from a government response standpoint, and we're repeating history. So this isn't the first time that we've observed a virus that depletes CD4 cells, right? SARS-CoV-2 and HIV, right? They both.
Right.
This isn't the first time that the infection is persistent, right? We've seen it with HIV. We've seen it with SARS-CoV-2. Folks don't like non-pharmaceutical interventions. They hate condoms and they hate masks, right? We're still attempting to vaccinate or create a vaccine with HIV. Our vaccines for SARS-CoV-2, they're not protective. They may be in some cases, but by and large they're not, or we wouldn't have millions of people living with long COVID. And we know that it's moving in a forward direction because, and a vertical direction as well. There's vertical and forward transmission because children are being impacted in the womb, and were it not transmitted in a forward direction, nobody would be getting infected, right? So, it's all there. I mean, the parallels are haunting if you really sit back and look at it. It's nothing more than a repeat of history.
So, at a high level, and I like grade 7 level, that's my favorite. What are the main parallels that you're talking about that you can sit very easily in the HIV world as you can in the SARS-CoV, because we're going to transition from there into what the SAND scan is that you've developed, because I think that's a good segue into that. So if we start at the HIV and SARS-CoV at a high level, what are those? Can you list those off easily, Daniel?
Sure can. So we'll talk about the parallels between HIV-associated neurocognitive decline and what I've described as SARS-CoV-2 associated neurocognitive decline, or SAND, which is where the SAND scan comes from.
Yeah.
And let me just say that, I'm not the only one who has made this connection and drawn these parallels. In fact, that parallel was drawn by a gentleman by the name of Kenneth Podel on September the 29th of 2020. One day after it became known that SARS-CoV-2 depletes the CD4 compartment, as does HIV. And in his paper, Kenneth Podel stated that it is to be expected individuals will suffer from the functional equivalent of HIV-associated neurocognitive decline after their SARS-CoV-2 infection. And in reading journal articles that have been published since that time, he's the most prescient individual in this entire pandemic. It is absolutely remarkable how he had it all pegged. So we can talk about all of the parallels now between the neurological complications experienced by those living with HIV and those living with SARS-CoV-2. So in December of 2021, a doctor by the name of Daniel Chertow at the NIH published a number of autopsy findings, and in doing so, he implicated the two most well-known reservoirs in HIV, that of the central nervous system and the gut-associated lymphoid tissues, which runs from the mouth to the anus, is the largest lymphoid organ in the body. So in the HIV positive, those reservoirs will expand through the formation of what are referred to as tunneling nanotubes. Okay? In 2022, Anna Pepe implicated the tunneling nanotube as the mechanism by which the reservoirs the central nervous system reservoirs were expanding in individuals living with a chronic SARS-CoV-2 infection. So what's interesting about that is if you read other journal articles, you'll learn that there is a connection between clogged arteries and cognitive impairment. There's actually a
Clogged.
study, clogged arteries
Clogged.
and cognitive impairment. So there is a paper that describes foam cell formation in those living with a chronic SARS-CoV-2 infection. That very same thing is observed in the HIV positive as a consequence of HIV's NEF protein. And if you read that paper on foam cells forming in those with long COVID, you'll find at citation number 33, foam cell formation, or I'm sorry, HIV's NEF listed. Now, what's interesting about that, which also explains the tunneling nanotubes, is that HIV's NEF causes foam cell formation and tunneling nanotube formation. So there's multiple other examples, and I'll certainly touch on those as well. So we have the hypothesis from Podal. We have the work of Dr. Daniel Chertow. We know that the same mechanism is expanding the reservoirs, the tunneling nanotube. Well, we also know that individuals are suffering from asymptomatic neurocognitive impairment, which is not observed in the ME/CFS population. They've been abused for whatever reason, and nobody has been able to determine what's causing their disease to be able to intervene when they are suffering from asymptomatic neurocognitive impairment. But Dr. Apple and a number of other individuals published their findings in January of 2022. They relied upon the test that is used to diagnose individuals with cognitive impairment who are HIV positive. So for those that are not neurocognitively normal, they have their impairment staged according to the Frascati criteria, which recognizes asymptomatic neurocognitive impairment, mild neurocognitive decline, and the final stage being AIDS dementia complex. 70% of her control arm met the diagnostic criteria for ANI and have been left to experience disease progression. Now, what we know about the HIV positive is that those who suffer from ANI are at a 2 to 6 times increased risk of conversion to further conversion to mild neurocognitive decline, and then, on and on until AIDS dementia complex. Now, what's interesting about the concept of ANI and this protein operating mechanistically as HIV's NEF is that long ago, what is referred to as the Trojan horse hypothesis was recognized with HIV. So you have these white blood cells that are called monocytes, and they will differentiate into what are referred to as macrophages. And so in October of 2021, the Trojan horse hypothesis was recognized. It was also that same month that we learned of individuals developing osteoporosis. Well, what are responsible for individuals developing osteoporosis? Those same monocyte-derived macrophages will differentiate into hyperactive osteoclasts, breaking people's bones down, and others are entering the brain, crossing a compromised blood-brain barrier, and become the primary target of HIV in the central nervous system, perivascular macrophages. Now, what's fascinating is about, like I said, these monocytes and this protein over here operating mechanistically as HIV's NEF, is that it leads to an elevation of what's referred to as CCL2. So when that is elevated, it's calling all of the horses into the corral known as the central nervous system reservoir. And just a few weeks ago, we saw further evidence that CCL2 is elevated in those living with the chronic SARS-CoV-2, which is leading to endothelial damage. So we've got these monocytes. We've covered the monocytes and the perivascular macrophages. That is a common cell type found within the central nervous system reservoirs of both individuals. So we also know that astrocytes are productively infected in both individuals. And if you read one article on their involvement in the brains of individuals living with long COVID, you'll see in the title, it plainly states they're in it for the long haul. Well, they certainly are, because they're among those cell types which serve as a reservoir in those living with HIV. So going back to this protein operating mechanistically as HIV's NEF and astrocytes that are loaded up with virus, it should come as no surprise that there was a paper published on the use of beta-adrenergic receptor agonist, because in the HIV positive, that is exactly what has been suggested because of astrocytes being productively infected with HIV's NEF, beta-adrenergic receptor agonist. So we have perivascular macrophages have been marked off the list, astrocytes have been marked off the list. And you published that or shared the article on YKL 30 being elevated in individuals. That is also elevated in individuals living with HIV. There's this bystander effect that you will observe, and there's a number of cytokines that are secreted by those macrophages, the Trojan horses that are taking their rider to a destination of dementia. And those same cytokines are elevated in those living with long COVID. And so those cytokines are resulting in those astrocytes becoming activated and secreting that YKL30. That biomarker is elevated in those living with sporadic Creutzfeldt-Jakob disease. Now, going back to that paper on foam cell formation that is being caused by a SARS-CoV-2 protein operating mechanistically as HIV's NEF. In the HIV positive and in the SARS-CoV-2 positive, foam cells are forming because of an impairment of a pathway, and it's called the cholesterol efflux pathway. Impairment of that pathway leads to the formation of foam cells and Creutzfeldt-Jakob disease. There is a journal article speaking on this, and it says the worst is yet to come. And with the way we're managing it, the worst is definitely yet to come. And so we've touched on astrocytes, and now we have the choroid plexus. As I mentioned to you earlier, I've lived with hydrocephalus for 43 years now, and so the choroid plexus is responsible for the production of cerebrospinal fluid. And there are individuals who have actually developed hydrocephalus after their chronic SARS-CoV-2 infection. And it's one thing to live with it from birth. It's a totally different thing to develop it later in life, like my landlord did when I found her out in the front yard when I was on the rescue squad. And she was an elderly woman and had to go to Vanderbilt and have a shunt put in after an aneurysm ruptured in her brain. And so she struggled with it quite a bit. because your balance is off. I mean, it can be something pretty horrible to deal with. We touched on vertical transmission, from mother to child earlier.
Yep.
There are those children that are experiencing enlargement of the ventricles in utero, so they're
I
coming
published a
out
lot
of the
about
womb.
that.
Yeah.
Yeah.
I'm sorry. What'd you say, Larry?
I said I've published a lot about SARS-CoV-2, COVID, and pregnancy, and I'm talking it's in the hundreds, if not thousands, of articles around this very subject. So it's a complicated subject. It's not a straight line, because
No,
even listening to you, right? Go ahead.
no, you're right. No, it's extremely complicated, and it's disturbing, as well. I mean, they're coming out of the womb without a fighting chance.
Yeah. So let me ask you a question that deals around, you've transitioned your thinking to help us understand between HIV, like the similarities between HIV and long COVID. You've got a SAND scan, which is a software. Explain how that connects into the long COVID world. Why does that connect into the long COVID world? What is the result of taking the SAND scan? So what is it, and then why should somebody care?
Yeah, well, there's a number of things. So, yes, you're right. I am working on a software program. I've put it on the back burner for a period of time. But the SAND scan is actually a cognitive assessment that I've put together that's built around HIV medicine and the work of Dr. Daniel Chertow, the book published by Hal Leonard, who is a neurologist, clinical neuroanatomy through clinical cases. So there are a number of concepts that we have ignored to the detriment of many, including the 8 million people who have reactivated tuberculosis. And because of that, we've imperiled their immune competence and their cognition unnecessarily. It was through the work of Dr. Daniel Chertow and others that they explored how quickly you must intervene in the HIV positive population if you want them to maintain their immunological health. And they did so through a paper describing what is referred to as the estimated date of seroconversion, when the individual is forming those antibodies when they feel like garbage. For me, I was rolling around in a bed with night sweats, and it felt like someone had thrown gallons of water on me. And what they found is that if you initiate antivirals in the HIV positive within 1 year of that estimated date of seroconversion, then they will experience what is referred to as a CD4 normalization, where those counts return to pre-infection levels. Mine has been as high as 1,700. Other benefits.
What does that mean? So I just want to stop you there for a
concept.
second. So you just said, you were at 1,700. I don't think people would understand that there's even a scale.
Sure. So, right. Anything 600 and above would be considered normal. So on the labs at Vanderbilt, the cutoff is 1,500 cells. And so mine has been outside of that limit by 200 cells. So, in the HIV positive.
And that's a test. That's a test. Is that a blood test?
Yes, it is. And thanks for asking. So the CD4 count, your CD8 count, the CD4 to CD8 ratio, those will not appear on a standard complete blood count with differential. You have to take it a step further and order a lymphocyte subset panel is what it's referred to. So that is ordered every time that I go to the doctor, which is every 6 months, after graduating from every 3 months. So once they ensured that I was on the right path, they let me graduate. And so that's obviously the primary cell that's attacked by HIV, and its depletion will lead to AIDS.
So the parallel. So the parallel we're making here is you're suggesting that if I just forgot about HIV for a moment, every time you said HIV, you're actually saying long COVID. Is that fair for me to say that?
Yes. Yes.
Because that's what this show is long COVID. It's not HIV.
Exactly.
But if there, but
No, you're right.
if you can, and that kind of sounded awful, and I didn't mean it to.
No,
What it,
no, I no, no, I
what the
no. I
parallel,
get what you're saying.
like the parallel I'm trying to make for my other scientists that watch this show and the other people that have HIV or not HIV, the long COVID is so you have a way of measuring because you just like you say you were above that measurement that was through a blood test, and you're saying that there's a
Yes.
way of normalizing that over a period of time. Did I read that correctly? Like you went back down into the safe territory. How did that happen?
Well, so I actually returned to the safe area. So within 90, so in
So
when
you
I
didn't
went
do anything.
and no, when I received my confirmatory test, when I
Right.
was at Vanderbilt, my CD4 count was at 600 cells, which is not normal. That was my lowest count, and an individual's lowest CD4 count is called their CD4 nadir. And there is
Okay.
no recovery of that CD4 nadir. You are to preserve it, just as you're to preserve an individual's cognition. And so, uh,
Okay.
yes.
Yeah.
So because I got into therapy, or got into care and on therapy, the CD4 normalization that I'm referring to is it returning to pre-infection levels, which has been as high as 1,700 cells.
Got it.
And
Now
so,
I'm starting to.
yes, so moving on to that CD4 nadir, it not only will predispose individuals to opportunistic infections like we're currently observing with the
Yeah.
reactivation of tuberculosis, 2,900 children being diagnosed with cryptosporidiosis in Australia, and increases in valley fever in California, which is coccidiomycosis. It also contributes to a number of pathophysiological processes which people are experiencing as well, including endothelial damage and cortical thinning. There was another paper that was describing cortical thickness in those living with a chronic SARS-CoV-2 infection. It was among those studies that relied upon the same criteria, the Scotty criteria, that Dr. Apple relied upon. And so while I can't remember the exact measurement, every loss of 100 cells, an individual will experience some degree of cortical thinning. And of course, there is no recovery of that cortical thinning. What's
So if I was to
interesting about
synthesize, and I, because what's starting to come, well, this is just kind of how I'm hearing it, is if I was to synthesize, is that this test, so you've got like what you're talking about, your test, you want to get that early in the game. If you think you have long COVID, you want to get that test done early in the game. Am I fair to say that? Because you need comparatives. Have I got that in the right
yes,
order?
yeah, yeah. I mean,
Okay.
it makes sense, especially going back to what we were talking about before, and that is the elevated monocytes contributing to an individual's asymptomatic neurocognitive impairment. Individuals can suffer from cognitive impairment and not be aware of it because individuals suffering from
Yeah.
ANI do not experience any difficulties with completing their activities of daily living, despite the fact that they do suffer deficits in a number of cognitive domains.
Interesting. Because I know that brain fog is not one of your favorite terms, and I get it. Because it's not really one of my favorite terms. It was one of those terms that came along, just like long COVID came along. It was a way of describing a commonality around a bunch of people. I was having this conversation yesterday with somebody. I have some cognitive rebound from having COVID. I'm still having a bear of a time. But now I'm thinking I'd actually like to get involved in what you're doing. I'd like to understand myself a little bit better, but I don't think I've got a baseline. If I was to get something done today, that would be my new baseline, but it wouldn't be the baseline from having the infection. If
Right.
that makes sense.
Well, it does. And, it's, I wanted to create an interview. So let me go back and say a few things here.
Sure. Sorry.
We,
Yeah, you go
we,
ahead.
no, that's fine. We have one of the things that I obviously ask about is their estimated date of seroconversion. So I know how far out that they've been from that. Are they past the 1 year? Because we touched on CD4 normalization and the CD4 nadir. The HIV positive are able to maintain a robust vaccine response with initiation within 1 year. Oculates use the hepatitis B vaccine to prove that. Obviously, the quicker you initiate antivirals, you're limiting the amount of reservoir expansion because those tunneling nanotubes, they're known for creating challenges when it comes to targeting them with pharmacological agents. So I want to find out about that. Then I ask them, hey, have you experienced any loss of the sense of taste or smell, dysgeusia or anosmia, right? Because we know that that's going to involve cranial nerves, right? We know that the virus has traveled up and found its way into what's referred to as the entorhinal cortex, which is right there in the center of the limbic system. So, as I've said on Twitter before, it's a home wrecker and it doesn't wear a wife beater and it doesn't have a mullet, right? But it destroys people's homeostasis, their olfaction, smell, their memory, and their emotions, because that's what the limbic system is responsible for. Then I asked them, have you experienced any diarrhea lasting for 30 days with a concomitant reduction in your body weight that's equal to 10% of whatever your body weight was? And the reason why I asked that is because of elevated cytokines. We know that individuals are experiencing an elevation in 3 cytokines that are horrible for cognition. IL-1B, rather, tumor necrosis factor alpha, and IL-6. Those are horrible for cognition in a number of different ways. So, tumor necrosis factor alpha, TNF alpha, that's the reason why folks are experiencing shortness of breath. Why some end up with, you've heard people talking about ARDS, or acute respiratory distress syndrome. Well, that will push you to ARDS, okay? And it can push you into the memory care facility as well. Because what is responsible for the creation of new synapses in the brain is called brain-derived neurotrophic factor. So when TNF alpha is elevated, then brain-derived neurotrophic factor is downregulated, okay? Now, there's 2 ways that BDNF can be transmitted. When it leaves that cell body, it's called anterograde transport. Tumor necrosis factor alpha prevents that. Now, what if you want to come back to the cell body, or retrograde transport? Well, ILB or IL-1B prevents the transmission in the other direction. And IL-6 elevation is the reason why individuals are experiencing depression and suicidal ideation. I mean, that's in journal articles that individuals can read. And we know from 40 years of evidence-based medicine that when IL-6 is elevated and tumor necrosis factor is elevated, that individual is in danger of imminent neuronal damage And it plainly states that in a journal article that is describing what is referred to as hypometabolism. And speaking of hypometabolism, we've known that it is developing in the brains of individuals living with long COVID since 2021. I believe it was either January
Delta.
or February.
Yeah, it's Delta.
We've ignored it despite knowing what the complications or the outcome for those individuals is going to be. When you defer resolution of an individual's hypometabolism, and this again appears in journal articles, then once it is resolved, the individual is left with irreversible neuronal damage. And so now, what's interesting about the diarrhea that I'm asking individuals about, and the IL-1B, is we've seen this before in the HIV positive due to HIV's TAT protein. It contributes to a number of pathophysiological processes that are being observed in those individuals living with long COVID, including IL-1B elevation. You talked earlier today, or in that paper on the YKL, it was talking about lung fibrosis. So that is observed in those living with the SARS-CoV-2 infection as a consequence of TGF elevation, tissue growth factor elevation. And so there is a protein E, is operating mechanistically as HIV's TAT. So that explains the TGF elevation. It explains another elevation, which is S100B, I believe, and it explains there was a study talking about wasting syndrome or cachexia in those living with a chronic SARS-CoV-2 infection. And it's TAT that will cause diarrhea in those living with HIV, and it's causing protein E is causing the same in those living with a chronic SARS-CoV-2 infection. Going back to that paper on YKL 30, it was talking about astrocytes. Okay, well, one of the other things among the other biomarkers that individuals are seeing an elevation of, or elevation in both populations, is GFAP. And there have been reports of individuals living with developing what is referred to as reactive gliosis. And so that is occurring as protein E operates mechanistically as HIV's TAT, because that is the protein responsible for causing that in the HIV positive population. So we've touched on paravascular macrophages, we've touched on astrocytes, we've touched on the choroid plexus, we can touch on brain pericytes. Their involvement has been known since 2021. We have known they harbor latent virus, contribute to blood-brain barrier degradation, and cerebral blood flow disturbances. In 2022, we learned that amyloid is depositing in people's brains. Now, there is a connection between amyloid depositing in people's brains and brain pericytes. Where's the rage that this is taking place? Well, it's in people's bodies. Protein E is causing an upregulation of rage receptors, as is observed in the HIV positive population, which is accelerating amyloid deposition in people's brains. And that is, that's what's taking place. What is also taking place is tight junction destruction. There is a journal article that specifically states that SARS-CoV protein E is leading to a destruction of these tight junctions. The consequence of that is cerebrovascular toxicity in the presence of amyloid, the very thing that is in people's brains. As is observed in the HIV positive population, individuals are experiencing deposition of phosphorylated tau, which is unsurprising considering protein E has consistently proven itself to operate mechanistically as HIV's tau. Now, there is one final cell type that we can discuss, the primary cell type that constitutes the central nervous system reservoir of those living with HIV and SARS-CoV-2, and that is microglial cells. We've known of their involvement since 2021. The authors let the cat out of the bag as to one of the neurodegenerative diseases that individuals may be befallen with, and that is Parkinson's disease. This was known in June. Beyond their involvement, there is the involvement of the basal ganglia, which Dr. Daniel Chertow observed persistence in all the way back in December of 2020 and 2021. You know, I mean, it's almost 3 years later. And then we knew of their involvement again 1 year after that, June of 2022. I don't know what it is about talking about microglial cells in June, but it seems to be somewhat of a habit. But beyond Parkinson's, individuals are predisposed to Alzheimer's disease, and they're also predisposed to amyotrophic lateral sclerosis and premature brain aging.
Yeah.
Now, what's fascinating about microglial involvement of Parkinson's disease and protein E is that individuals are experiencing microglial ferroptosis, contributing to Parkinson's development, just as is observed in the HIV positive as a consequence of HIV's TAT protein. So it's operating exactly in the same way. Another pathophysiological process that is common as a consequence of protein E operating mechanistically as HIV's TAT is excess calcium release from neurons. Those authors actually plainly stated in there that, you know, this is observed with HIV. You know, so there's been plenty of hints of in papers that the wrong parallels were drawn. You know, and
Right.
you know the consequences are going to be great. You know, I don't know if you saw not too long ago that the Washington Post came out with an article talking about Parkinson's disease and a test under development for the detection of asynuclein or not. Did you see that?
I posted it actually. Yeah, I posted it on my social media. I tend to post a lot of stuff from, you know, the more reputable agencies. And we've only got a couple of minutes left, Daniel.
Sure, no
How
problem.
do you So I'm gonna. Let me ask you this. So I'm gonna have to get you back on because there's more to this.
Sure.
What is the future in what you're doing as it relates to long COVID? Where are you heading
I'm sorry?
with this? Where are you heading with this personally in your studies and in your science? Where are you heading with this as it relates to long COVID? What's the future look like for you?
Yeah, you know, I don't know. You know, I'm going to continue, you know, to try to point out that this is, you know, we're just running around in circles, you know, for no reason. You know, and continue to operate, you know, my business. You know, I will say that I do find it quite disgusting what has been done to millions of people due to anemic advocacy. And, you know, so there have been times when I've said, hey, I'm going to DC, you know, throw in some money or that kind of deal if you want to send me. But you know, I've self-funded, the
Yes.
advocacy that I've done, and you were talking about my Twitter involvement. I had no idea that I'd turned out almost 79,000 tweets since I started. Yeah, just like I said, continuing, to use my knowledge, from a patient perspective, and then I picked up my first anatomy and physiology book back in 1996. So it's always been a passion of mine. Possibly looking to work with people that are suffering from the same neurological complications that I am. I've not really given it a tremendous amount of thought.
Well, and you know what?
Just taking
I'm
it one
not.
day at a time.
Yeah, I'm not of a mind that we have to have some chiseled in concrete future as to where we're going. I have no idea where I'm going with this, but I just know that I'm not
Right.
going. I'm not going to stand still. You know,
No,
I've
and we
got.
can't. No,
Yeah,
no.
agreed.
This is a society shaping exercise, right?
It
And
sure is.
previous
Yeah,
generation, yeah, previous generations kicked the ass of visible threats and during times of war. And we're the most
right.
well-connected society that has ever existed, and we can't kick the ass of an invisible threat. Now just
Yeah,
think about how pathetic that is. I mean,
yeah.
just look at the mess. You know, I mean, this is utterly insane. You know?
Well, thank you, Daniel. I appreciate today.
Yeah, you're more than welcome,
You're
Larry.
definitely. I'm going to get you back on again because there's more to this.
Yeah, we've got a lot more to
Have a
talk
great day.
about, and
Yeah, we sure do.
yeah, you do the same. Looking forward to it, Larry.
Yeah.
You
You
take
take
care
care
of
now.
yourself.